Hello, my name is Ailsa Butler and I'm an author on the Cochrane Review of Interventions for Quitting Vaping. Today I'm going to talk to you about the results from our new review published in January 2025. This slide lists all of the authors on the review. Here are our funding and declarations. This work is supported by Cancer Research UK. Most authors have no conflicts of interest to declare. Nancy Rigotti and Lynn Dawkins have received consultancy fees. Please see the review for more detail. So what is Cochrane? Cochrane's a global non-profit organisation. The best available evidence is brought together, systematically reviewed with an emphasis on quality assessment. We bring together the evidence and combine the results to see what they show. We consider how much we can trust the results. This evidence helps to improve knowledge and to feed into healthcare decisions. Cochrane methods are considered gold standard. Healthcare providers, patients, carers, researchers, funders, policymakers and guideline developers worldwide use the results of Cochrane reviews to improve their knowledge and make decisions about healthcare interventions. What do we want to find out? There is limited advice available on the best ways to stop nicotine vaping. We bring together up-to-date information to see what tools have been tested for this purpose and whether they can help people to stop vaping. We look at any harms these interventions may cause, including whether they could cause more people to smoke tobacco. Why is this topic important? Nicotine vapes expose users to less of the substances that cause disease that are present in tobacco cigarettes. Vaping is likely to cause more harm than not vaping. Some people vape nicotine to help them quit smoking. However, some people who vape nicotine have never smoked. People may want to stop using vapes containing nicotine, but find it difficult due to nicotine's addictive properties. Which interventions could help people to stop vaping? Medications such as nicotine replacement therapy, or NRT, for example, patches and gum, varenicline, bupropion, and cytosine. These medications are already used to help people stop smoking and could be used for stopping vaping. And behavioural interventions such as counselling, text messaging, and online support. Living systematic review. So the evidence base on how to stop using vapes is rapidly evolving. In order to provide the most up-to-date evidence, we are transitioning to a living systematic review and will search for new evidence monthly, publish links to new evidence monthly, and update the review when data emerges that changes, strengthens, or weakens conclusions, or relates to new comparisons or outcomes. As many studies are in the pipeline, the living format is well suited to this fast-moving policy-relevant topic. We searched 6 databases to April 2024. We contacted researchers. We searched clinical trials that are planned or in progress and the abstracts of the SRNT, the Society for Research on Nicotine and Tobacco's annual meeting. And going forward, we will carry out monthly automated searches of the databases. Our objectives are to assess the benefits and harms of interventions to help people stop vaping compared to each other or to placebo or no intervention, and to assess how these interventions affect the use of combustible tobacco. Our inclusion criteria. So we include randomized controlled trials, including crossover trials, where people of any age using nicotine-containing vapes, regardless of tobacco smoking status, are randomized to an intervention or to a control. Randomized controlled trials are considered the best way to test for effects of treatments. Studies had to test a stop vaping intervention and measure at least one of our outcomes: vaping to between 3 to 6 months, or 6 months or longer, measure change in tobacco cigarette use, or measure harms at 1 week or longer. So our review includes a number of different outcomes and comparisons, and it's too much to cover in a short presentation. In this presentation, I will focus on our critical outcomes and comparisons and briefly describe our important outcomes. So our critical or primary outcomes are vaping cessation at 6 months or longer, change in combustible tobacco use at 6 months or longer, number of participants reporting serious adverse events, SAEs, at 1 week or longer. Our important or secondary outcomes are vaping cessation between 3 to 6 months, change in combustible tobacco use between 3 to 6 months, number reporting adverse events, AEs, at 1 week or longer, number vaping a substance other than nicotine at 3 months or longer, changes in weight between baseline and longest follow-up, changes in alcohol use between baseline and longest follow-up, and changes in biological markers at 1 week or longer, e.g. carbon monoxide, blood pressure, lung function, and known toxins or carcinogens. There are 9 randomized controlled trials included in our review and include over 5,000 participants. 8 studies were conducted in the USA and 1 in Italy. All participants were motivated to quit vaping. There was 1 study among 13 to 17-year-olds, 3 studies in 18 to 24-year-olds, and 5 studies in people aged over 18. 3 studies were judged at low risk, 3 at high risk, and 3 at unclear risk of bias. and funding for 4 were funded by the manufacturer or provider of the intervention. Here are our main comparisons. So we compare NRT to control, cytosine to placebo, varenicline to control, nicotine vaping reduction to minimal support, and text message-based interventions to no minimal support for nicotine vaping cessation in young people 13 to 24 years. So here are our findings. In these forest plots, the vertical line drawn at 1 is the line of no effect. There's a red arrow to show this. If the data falls on this line, there is no difference between the comparisons. Grade ratings evaluate the certainty in the evidence, and we only assess grade for our critical outcomes. So turning to our first comparison, combination NRT versus control for quitting vapes at 6 months or longer, shown in the top plot. The plot estimate for the one study by SAR 2021, which was rated at high risk of bias, indicated higher nicotine vaping cessation rates at 6 months follow-up in people randomized to receive combination NRT versus referral to a smoke and quit line. However, the study was very small, 16 participants, and so results were imprecise, with 95% confidence intervals incorporated the possibility of no difference between arms or higher quit rates in the referral arm. The relative risk was 2.57. The 95% confidence interval spanned 0.29 to 22.93, with very low certainty evidence, and this is reported in analysis 1.1 in the review. For vaping cessation between 3 to 6 months, 2 studies reported this, Klein 2024 and SAR 2021, with 524 participants in total. When pooled, the effect estimate indicated higher rates of quitting in the no/minimal support groups. However, the confidence intervals covered the potential for no effect and a benefit of combination NRT. The relative risk was 0.93 and the confidence intervals were 0.45 to 1.93. So turning to serious adverse events for combination NRT versus control, a single study by Klein 2024 with 508 participants and rated at unclear risk of bias reported at no SAEs in either the combination NRT plus behavioural support study arms or the control study arms, with behavioural support matched to their respective interventions arms. Therefore, it was not possible to calculate a relative effect. This evidence was judged to be of low certainty, downgraded 2 levels due to imprecision, and no events were recorded across study arms. The same study by Klein was the only study that reported non-serious AEs, adverse events, and found evidence of more participants reporting AEs in the 2 study arms receiving combination NRT than the 2 control arms. The relative risk was 2.74. Confidence intervals spanned 1.97 to 4.17, and the participant number was 379. None of the included studies comparing combination NRT with no minimal support reported change in combustible tobacco use at 6 months follow-up or longer. Our next comparison is cytosine versus placebo. Only one study judged to be at low risk of bias with 159 participants and funded by the intervention manufacturer contributed to our cytosine versus control comparison. This study did not report vaping cessation rates at 6 months or longer. The study by Rigotti et al. 2024 measured nicotine vaping cessation at 4 months follow-up and found that more people stopped vaping in the cytosine group than in the placebo control group. However, the confidence intervals incorporated the null and a potential benefit of placebo. The relative risk was 1.77. The confidence interval spanned 0.82 to 3.82. There were 160 participants, and the study was judged to be at low risk of bias. The study by Rigotti was the only study that reported change in combustible tobacco use. No participants were smoking at study baseline, and their use of combustible tobacco was monitored to 4-month follow-up. 8 out of 107 people used tobacco cigarettes in the cytosine arm, and 6 out of 53 in the placebo arm. The 95% confidence intervals were wide and incorporated 1, so the relative risk was 0.66. The confidence interval spanned 0.24 to 1.81. 11 of the 14 participants who reported smoking across study arms had previously smoked. This was not broken down by study arm. So looking at serious adverse events for cytosine versus placebo, no participants in the study by Rigotti reported serious adverse events. As no events were reported across study arms, it was not possible to calculate a relative effect, and we deemed the evidence to be of low certainty, downgraded 2 levels due to imprecision. For adverse events, there was no clear evidence that the number of participants reporting adverse events differed between arms. The 95% confidence intervals incorporated benefit, harm, and no effect. So the relative risk was 0.93. The confidence intervals were 0.68 to 1.27. We now look at the results for varenicline versus control as a quit vaping tool. One study by Capinetto, judged to be at low risk of bias, measured vaping cessation at 6 months or longer. This study, with 140 participants, reported evidence that more participants quit nicotine vaping in the varenicline arm than in the placebo comparator arm. The relative risk was 2, and the 95% confidence intervals were 1.09 to 3.68. We deemed the evidence to be low certainty, downgraded 2 levels due to imprecision. This study was funded by the manufacturer of the intervention. 3 studies reported vaping cessation at between 3 and 6 months follow-up, the lower plot, so Capinetto, Ficito, and an NCT record. Together, there were 182 participants and a relative risk of 1.64, indicating higher quit rates in the varenicline groups. However, the confidence intervals, 0.98 to 2.74, incorporated the potential of no difference in quit rates between the varenicline and control. When the one study judged to be at high risk of bias was removed, the NCT record, the effect estimate suggested a clearer benefit of varenicline. One relative risk of 1.78, confidence intervals 1.12 to 2.82. Removing the one study funded by the intervention manufacturer, Capinetto 2023, resulted in a relative risk of 1.13 and confidence intervals spanning 1. Confidence intervals of 0.47 to 2.72, increasing the uncertainty of the possibly positive effect. However, this result should be treated with caution due to the small number of studies and the overlap in the confidence intervals resulting from the main analysis and the sensitivity analysis. 3 studies investigating varenicline measured the number of participants reporting serious adverse events. However, only one study, Capinetto, reported 1 SAE, serious adverse event, in the intervention arm. Therefore, the effect estimate was calculated based on that single study. The relative risk was 2.60. The 95% confidence intervals were 0.11 to 62.16. There were 95 participants. Low certainty evidence downgraded 2 levels due to imprecision. As Capinetto 2023 was funded by the intervention manufacturer, we plan to exclude this study in a sensitivity analysis. However, neither of the remaining studies reported SAEs in either arm, hence an effect estimate could not be calculated. The grade certainty of evidence was downgraded 2 levels due to imprecision. Very few events and confidence intervals incorporated the potential for benefit, harm, and no effect of the intervention. Turning to adverse events, the lower plot, 3 studies reported these. The pooled estimate was imprecise, with the 95% confidence intervals incorporating potential harm, benefit, and no effect of varenicline. The relative risk was 1.19, confidence intervals 0.84 to 1.68. There were 130 participants. So removing the one study judged to be at high risk of bias and the one study funded by the intervention manufacturer in separate sensitivity analysis did not change the interpretation of the results. In one small study, with 17 participants by SAR, the point estimate suggested nicotine vaping reduction increased vaping cessation compared to minimal support at 6 months follow-up. But the confidence interval incorporated the possibility of no intervention effect and higher cessation rates in the control arm. The relative risk was 3.38. Confidence intervals were 0.43 to 26.30. There was very low certainty due to imprecision and risk of bias. So looking at the lower plot, SAR 2021 also measured nicotine vaping cessation at 3 months follow-up. There were marginally higher quit rates in the minimal support groups. However, the 95% confidence interval was wide again, so that was 0.96. It was wide. The relative risk, so it was 0.96. The confidence intervals were 0.57 to 1.64. This one study investigating nicotine or vaping behavior reduction did not report on SAEs or change in combustible tobacco use at 6 months follow-up or longer. Now, looking at text message-based interventions, our last comparison in this slideshow. There is low certainty evidence downgraded 2 levels due to indirectness that a text message-based intervention may increase nicotine vaping quit rates in 13 to 24-year-olds in comparison to no or minimal support 7 months after the intervention start. There were 4,091 participants. The relative risk of 1.32 was 1.32. The confidence intervals did not cross 1. Graham 2021 judged at low risk of bias, and the NCT record, now published by Graham et al., judged at unclear risk of bias. So both compared the same text message in nicotine vaping intervention. Both of the studies included in this analysis were funded by the Truth Initiative, who provide the text message-based intervention, and both were carried out in young people, one in 13 to 17-year-olds and one in 18 to 24-year-olds. And now looking at the lower plot, the study by Klein, judged to be at unclear risk of bias, reported nicotine vaping cessation at 3 months. There were 196 participants. Cessation rates were slightly higher in the text message-based intervention. However, the confidence intervals incorporated no difference and a potential benefit of the control. So the relative risk was 1.05. The confidence intervals were 0.84 to 1.31. Finally, one of the studies investigating text message-based interventions report on SAEs. However, 0 events were reported in both study arms. There were 508 participants in this analysis. Evidence was low certainty, downgraded 2 levels due to imprecision. Klein 2024 reported the number of participants reporting adverse events, the lower plot, resulting in a relative risk of 1 and a 95% confidence intervals, also incorporating a potential benefit and harm of the text message-based interventions. So the confidence intervals span 0.7 to 1.44. The number of participants in this analysis was 379. So all Cochrane reviews end with implications for practice and implications for research. These are important, and I will read through these. So there is low certainty evidence, downgraded 2 levels due to indirectness, that a text message-based intervention may increase nicotine vaping quit rates in 13 to 24-year-olds in comparison to no or minimal support 7 months after intervention start. There is low certainty evidence, limited again by imprecision, that varenicline may increase nicotine vaping quit rates versus placebo. However, further data may change this conclusion. Risk of bias and imprecision preclude conclusions regarding the effects of combination nicotine replacement therapy, cytosine, and a nicotine concentration and vaping behavior reduction program on nicotine vaping quit rates. There is very limited evidence looking at serious unintended consequences of pharmacotherapies or behavioral interventions for quitting nicotine vaping, making it difficult to draw conclusions on potential harms. Where measured, rates of SAEs were extremely low across arms. The pharmacological interventions tested, so combination NRT, cytosine, and varenicline, are licensed for the purpose of quitting smoking globally and considered safe for that indication. There is very limited evidence on the effectiveness and potential harms of interventions combining behavioral support and pharmacotherapies for vaping cessation and comparing relevant interventions head-to-head. None of the included studies reported whether nicotine vaping cessation interventions had an effect on the number of people smoking combustible tobacco cigarettes at 6 months or longer, and results of the one study measuring this at 4 months were inconclusive. Here are implications for research. More research is coming out, and we would like to thank all the researchers and participants for contributing to this research. We are aware that there are always funding constraints, but we recommend that further randomized controlled trials should follow up for 6 months or longer, measure rates of vaping cessation, assess safety profile for as long as possible, measure impacts of the interventions on rates of combustible tobacco smoking, continue to investigate interventions effective for tobacco smoking cessation and other interventions, including financial incentives and counselling. Use comparator arm where vaping cessation was not encouraged, i.e. no treatment provided, to assess effective vaping cessation interventions on tobacco smoking rates. So the second side of implications, be powered and have processes in place to counteract risks associated with blinding and attrition, for example, placebo as a comparator, balancing face-to-face contact between study arms, biochemically validating vaping and smoking status, and optimizing follow-up contact procedures. Consider dependence levels and clearly specify the baseline characteristics of participants in terms of vaping and/or smoking history. Research text message-based interventions to help people stop vaping in older adults, and test other text message-based interventions. So ongoing studies. We have identified 20 relevant randomized controlled trials that are underway and will help us learn more about what interventions could be used to help people to stop vaping nicotine. These new trials look at a wide range of different interventions, for example, school and web-based lessons, more on varenicline, some on NRT and on behavioural support, plus NRT, also incentives, adverse health warnings, smartphone apps, telephone-based support, and video call-based support. So please see the review for more detail on these ongoing studies, and we're excited to see the outcomes of these trials and to see more trials start. For further information, please see our briefing documents, our podcast, our review, and our webpage. These will provide more detail on everything I've just presented, on the secondary outcomes and other comparisons. This link will give you access to all of these sources of information from our webpage. Thank you for listening.